Hey everyone, so I wanted to quickly go over Unit 5, which is our neuro section. I know we didn't get to finish all of the slides on Friday, so first I wanted to do a recap of some of the stuff that we talked about Friday, and then we can go over the slides that we never got to discuss. So first, with the brain function, we know that with the left hemisphere and the right hemisphere, they both have different signs and symptoms, and depending on which area of the brain has the lesion or the brain damage, we can determine what kind of symptoms, signs and symptoms our patients are going to be experiencing and how we as nurses are going to respond to that. So with the left hemisphere, that's language dominant for most patients. So reading, writing, math, logic, they're all going to be affected. So injury to the spot is going to cause aphasia, poor word finding, difficulty with calculations. Right hemisphere is going to be in charge of spatial awareness, visual spatial skills, creativity, insight, those nonverbal cues. So injury to the side is more like neglect, poor judgment, increased safety risk. So we got to figure out how we can make our patients safe, how they can communicate with us, and basically not have them fall to the ground if they do have that right-sided hemisphere damage. Now for the rapid neuroassessments, we know that the NIH stroke scale is going to be the standardized tool to use to determine whether someone's having a stroke or how severe that stroke is. Now, you are not expected to remember the entire point system for this, but you are expected to know what it is, what it tests for, and just the different categories that it tests for. So for the GCS or Glasgow Coma Scale, this is going to be used on pretty much anybody with any kind of neurological deficit. So this focuses on eye opening, motor response, and verbal stimuli. The highest score you can get is 15, lowest score you can get is 3. Now just remember that 8 and below, that usually indicates a severe brain damage and it might need intubation. So these are your high priority patients and you need to do something quick about it. Also remember that when you're trending your GCS scores, any kind of 2 points or more drop in the score, that's going to be a cause for concern. That might reflect any kind of worsening cerebral function and any kind of risk for secondary injury. So this needs to be escalated to the doctor quickly. For the diagnostic testing and procedures, get your vital signs first, and then if you need a cost-effective, fast way to detect a bleed, we use a CT or a CTA. So again, that's going to detect bleed, any vascular occlusions, any acute changes. The MRI or MRA, that's more sensitive for ischemia, soft tissue damage, or anything that has to do with the brainstem or cerebellum. And if there's any kind of stenosis or embolic risk, we can evaluate the carotids with the carotid ultrasound. And we know for stroke, there can be a cardiac etiology, so we can use an echocardiogram to look for any cardiac source for the emboli. Lumbar punctures, we have to be careful with this, especially if someone has an increased ICP, because we know that if we do this, we're relieving the pressure because of the Monro-Kelly hypothesis. We're relieving the pressure through that puncture site, and the brain might herniate if we do that. And for the blood work, this can detect any kind of infection, any metabolic causes, or determine the coagulation status for our patients to see if that has anything to do with what's going on with them. Altered level of consciousness, that's going to be the most sensitive indicator for neurological status. Remember the continuum, it goes from alert to lethargic to obtunded to stuporous, then to coma. Now for headache, otherwise known as cephalgia, we know that this is one of the most common complaints, but we got to figure out what's causing it first so that we can appropriately treat our patients. There's 2 types, primary and secondary. So primary headaches have no organic cause, and that includes a migraine. These migraines, they're often hereditary and it affects about 12% of adults. It can have severe throbbing, pain with nausea, sensitivity to light or sound, and it can be triggered by certain foods, hormones, stress. Now, with tension headaches, which is the most common primary headache, you'll have a tight band feeling lasting about 30 minutes to several days, and this can be triggered by stress, muscle tension, poor posture, and then we have cluster headaches, which is male-dominated. This is your severe cyclical pain. It can be around one eye. It can last about 15 minutes to several hours and occurs over weeks to months. Now, for secondary headaches, in addition to brain tumor or aneurysms, it can be caused by severe hypertension or head injury or even meningitis. Depending on what's causing the headache, then we can determine what we can do to help the patient, whether that's abortive or preventative medication. Abortive is anything acute, and preventative is to help, of course, prevent future headaches from happening. Sumatriptans are going to be the first line medications for migraines. This can cause vasoconstriction, decrease inflammation, decrease pain transmission. So we know that with migraines, it's a vasodilative condition, so that's why this is going to be the most helpful. Now, for increased ICP, any changes in level of consciousness is going to be your earliest and most sensitive sign. One of the late signs, which is Cushing's triad, includes widened pulse pressure, bradycardia, and irregular respirations. Again, an easy way to remember this is to remember the signs and symptoms of sepsis. One of the important things to remember is that increased ICP can be treated non-pharmacologically, such as quiet environment, elevating the head of the bed at least 30 degrees, avoiding neck flexion, and clustering your care so you don't put a lot of stress on the patient. And then we can try to do some medical management, such as IV mannitol, to decrease excess fluid in the brain. Now for seizures, these are your sudden, uncontrolled electrical discharges in your brain. Sometimes it involves one hemisphere, which is your focal seizures. Sometimes it involves both hemispheres, which is going to be your generalized seizures. Sometimes we just don't know what's causing it. The etiology is unclear. With your provoked seizures, it can be triggered by acute reversible conditions. So we just got to figure out what those conditions are, and then we can treat it appropriately. As for the diagnostic test for seizures, your EEG is going to be the most common imaging study to be ordered for your patients that come in with seizures. Now, CT and MRI, that can be used depending on if there's any structural abnormalities that is causing the seizure. And then PET or SPECT can be used to see if there's any kind of vascular etiology. As nurses, we're in charge of making sure that the patient is safe before, during, and after a seizure. So if there's any kind of aura or triggers that are causing the patient's seizures, let's identify that and remove that from the situation. For the ictal phase, safety is paramount, as well as documentation and timing. We want to make sure we also protect the airway in the post-ictal phase and reorient them and see if there's any kind of injury that happened during the ictal phase. Now, the focus for seizure treatment is to control the seizures, identify the underlying cause, and prevent any kind of recurrence. Make sure we assess for any kind of metabolic, infectious, structural, or withdrawal triggers, and monitor for any kind of interactions with drugs or food. So we have to monitor the drug levels for any kind of seizure medications that they're on. For medical management, the anticonvulsants, we have to make sure that they're at therapeutic levels. Your lorazepam is going to be your first line medication for any acute seizure activity, and then we can use diazepam if needed. Now let's talk about stroke. There are non-modifiable and modifiable risk factors. Your high blood pressure or hypertension is going to be your primary modifiable risk factor that can help prevent stroke. I want you to not only remember these risk factors, but also identify why they are risk factors in the first place. There's 3 types of strokes. We talked about TIA, hemorrhagic, and ischemic strokes. The important thing about TIAs is that we got to make sure that the patient is aware that this is a warning. You might get a stroke later on, a full-on stroke. So you are not in the clear yet. Although the symptoms are temporary, we have to make sure that if they have a lot of risk factors, that they take the medications that are prescribed to them to help prevent any kind of full-blown stroke in the future. Now, you'll see a lot of similar symptoms between ischemic and hemorrhagic stroke. The important thing to remember is that with hemorrhagic stroke, it's going to sound like the worst headache of their life, and their signs and symptoms are just going to happen more rapidly. Remember the TPA considerations. This is a powerful clot-busting drug, so we got to make sure they don't have any contraindications to us giving them TPA. So remember, patients that come in for a stroke and they have a blood pressure in the 170s after being treated, that's generally okay. We want them to have a permissive hypertension. Protocols are in place so that the brain keeps getting blood perfusion. With the AVMs or arteriovenous malformations, these are your congenital tanglement of arteries and veins. They don't have any capillaries, they have weak vessel walls, they can dilate, and they have a risk for ruptures, especially in your older adults. This is usually diagnosed with a CTA or MRA, and our job is to make sure we control their blood pressure, any kind of seizure precautions. We need close neural monitoring, and most importantly, avoid an increase in ICP. Now let's talk about management of patients with neurological infections, autoimmune disorders, and neuropathies. First, we'll go over trigeminal neuralgia, which also is called tic douloureux. This is a disorder of your cranial nerve 5, which causes sudden, severe facial pain. The patho behind this is that there's some vascular compression that's happening, which increases your nerve hypersensitivity. It's most common in your maxillary and mandibular nerve. Your high-risk groups are your women in the ages of 50 to 60s and patients with MS. This can be triggered by light touch, chewing, brushing teeth, talking, cold air, and some of the pain patterns include brief stabbing, electric shock-like pain. This can last from seconds to minutes. So how is this going to impact our patients? So if they're having pain, they're going to avoid eating, they're probably not going to have the best hygiene, and their social interaction is probably going to be minimal. So we got to make sure we center our nursing interventions around those functional impacts. So this is just a picture of the cranial nerve 5 branches. V1 is going to be your ophthalmic, V2 is your maxillary, and V3 is your mandibular nerves. With the V1, that affects mostly your forehead and your eye area, and your V2, that's mostly your cheek, upper lip, and upper teeth. And V3 is going to be your jaw, your lower teeth, your chin, and your motor muscles in charge of chewing. Just know that trigeminal neuralgia most commonly affects V2 and V3, so cheek and jaw pain are going to be common. So if your patient has facial pain that's triggered by brushing their teeth, it's more likely that they have trigeminal neuralgia, not a dental type of pathology. Now, how do we treat this? Our first line medications are anticonvulsants, specifically carbamazepine. That's going to be our first line. We take that with food, and we want to make sure we monitor their CBC and liver function. We can use adjunctive therapy meds, which are your phenytoin or baclofen, for muscle-related triggers. If needed, we can do surgery, and that's only reserved for any kind of refractory cases. So for example, you have your microvascular decompression. This helps relieve vascular compression on the nerve. You have your radiofrequency ablation. This actually destroys the pain fibers via heat. And then we can also do balloon compression, which compresses the nerve root to block that pain transmission. Some of the post-op risks include facial numbness and chewing difficulty. So for the nursing interventions, we want to make sure we prevent pain, of course. So we need to identify and avoid the triggers. If the patient is having pain whenever they chew on the right side of their mouth, maybe switch to the other side of the mouth and see if that helps. We want to avoid triggers like cold air, touching the affected side, and chewing on the affected side. And again, these people are in pain, so if they're having facial pain, they might avoid washing their face. You gotta assist with face washing if the patient's avoiding contact with that. And just be mindful and make sure that you're gentle. As for nutrition, we can use soft foods so that they don't have to work as hard to chew. We can also chew on the unaffected side, like I said, and avoid hot or cold foods. For emotional support, we gotta make sure, again, we acknowledge their anxiety and depression because they're having chronic pain. We don't want to fix it yet. First, you gotta acknowledge and reassure. We also have to educate them. Medication adherence and early symptom reporting is vital. So let's talk about Bell's palsy. Bell's palsy is an inflammation of your cranial nerve 7. It causes unilateral facial paralysis, and that's important to remember. Unilateral facial paralysis. This occurs acutely and suddenly. Some of the key symptoms to this is a facial droop, inability to close their eyes, inability to wrinkle their forehead, inability to smile or puff their cheeks. They might have possible ear or facial pain. There's usually no changes in level of consciousness for these patients. They usually don't have any limb weakness. So if we can appropriately identify these symptoms, we can rule out a stroke. Now, if we can rule out a stroke, then that'll help us determine the treatments we can use. For this particular condition, we want to make sure we start corticosteroids early, because remember, this is an inflammation of the cranial nerve 7, so corticosteroids will help reduce inflammation. We can also use antivirals if HSV is suspected. Because they have difficulty or the inability to close their eyes, they need eye protection with artificial tears and patching so that they don't have any kind of trauma or damage to their eyes. For these patients, they have a loss of muscle tone, so in order to regain that muscle tone back, we can even do a facial massage after the pain subsides, just to help with that muscle tone. Another main difference between this and a stroke is that these patients can recover in about 3 to 5 weeks. So remember, Bell's palsy affects the entire face, including the forehead, and has no limb weakness or level of consciousness changes. So if this happens, it's probably not a stroke. So let's talk about degenerative neurological. For Parkinson's, this is going to be your slow, progressive neurological movement disorder. This is a loss of dopamine in the substantia nigra. And one way to remember the patho behind Parkinson's disease is that there's no dope in the park. It's a loss of dopamine that leads to impaired motor control. It causes movement disorders such as bradykinesia, rigidity, tremors, postural instability, and this condition is chronic and progressive. The goal here is symptom control and preservation of their independence. Some of the risk factors here include genetics. There's a familial link to this in about 10 to 15% of cases. Some are environmental, which includes chemical and metal exposure, pesticides, solvents, rural living, and well water. If you're over the age of 40 years old, that increases your risk. A decrease in estrogen may also increase your susceptibility. And unfortunately for men, they are at an increased risk to develop this than women. Another risk factor for this could also be a prior mild traumatic brain injury or TBI. This can also increase your risk. Now for Parkinson's symptoms, there is a clear core cluster of symptoms that you can identify to see if they have Parkinson's disease or something related to Parkinson's. This is your TRAP symptoms. T meaning tremor, R is rigidity, A is your akinesia/bradykinesia, and your P is your postural instability. So TRAP is going to be your acronym to help remember these symptoms. Your resting tremor can include pill rolling. It's a unilateral onset typically, and this increases with stress and it decreases with movement. Your rigidity includes stiffness, cogwheel resistance, muscle pain, and a decrease in your arm swings. Bradykinesia usually involves slow movement and difficulty initiating the motion. They're also going to be slow in performing their ADLs. Postural instability will include a stooped posture and a loss of balance, which increases their risk for falls. And these are just some of the symptoms that we already talked about. So motor appearance is going to be slow, stiff, stooped, and shuffling. Their gait, they're going to have short steps. They're going to have a forward lean usually and reduced arm swing. For tremors, hand is going to be the most common area, and it may involve the head or other extremities. The rigidity limits their range of motion, and that can cause discomfort for them. And for their facial expression, it's usually masked, and their blinking may decrease as well. Some of the other symptoms include loss of automatic movements. So again, decreased blinking, decreased smiling, arm swing, and their speech is going to be soft, monotone. It can also be slurred, and they can hesitate. They may repeat some words. Also, anyone with Parkinson's disease, they can develop dementia in the later stages. And because of all these symptoms, depression is going to be common among these patients. They're also going to have insomnia, which is more than 75% of these patients. They'll frequently wake up. They're going to have sudden daytime sleep attacks, and we want to make sure we focus on their safety. So if there's any sudden sleep episodes, this means that you can't let them drive or operate any kind of motor vehicle. Now, when we're talking about swallowing, they can develop dysphagia in the later stages, which increases their risk for aspiration. For the autonomic symptoms, they can develop orthostatic hypotension, which of course will cause them to have dizziness and increase their risk for falls. They may also have urinary incontinence or retention. They might have constipation from the slowed motility in their GI tract. Sexually, their libido is going to be low. Overall, our clinical priority is to make sure that they don't aspirate and they don't fall. So we want to make sure we stop PO intake if a patient starts to cough while they eat, because coughing could suggest that their swallowing reflex is impaired, and of course that's going to increase their risk for aspiration, and they'll need a swallow eval. Now, for the diagnosis piece for Parkinson's, there's no specific test for this. It's more of a clinical diagnosis. There's no single confirmatory test. Labs and routine imaging are not helpful for diagnosis. We want to rule out other neurological disorders first. We want to make sure we get a thorough medical history and a neurological exam. This neuro exam will focus on their gait, their coordination, and simple hand tasks. Now, here's the important thing to remember. For the diagnostic criteria, they must have 2 or more of the 4 cardinal symptoms. So remember, the cardinal features are TRAP, tremor, rigidity, akinesia or bradykinesia, and postural instability. And sometimes if we need advanced testing, we can use a PET scan, which may help if diagnosis is unclear or the disease has progressed. For the medical management piece, our primary goal is to control the symptoms and maintain functional independence. Our treatment focus is going to be dopamine replacement or dopamine enhancement. And the medication we use for this is levodopa with carbidopa. A nursing consideration for this is we have to make sure that we schedule their ADLs during their medication on periods. So basically, we got to make sure we time it along with their ADLs. Some of the long-term effects of levodopa includes dyskinesia because of the dopamine fluctuations over time. And if we need to, there are surgical options. A thalamotomy helps with tremors. A pallidotomy is to help with rigidity or dyskinesia. These are lesioning procedures which are permanent and usually unilateral. Now, there are some research with neurotransplantation, but this is experimental and it's an ongoing research, so it's not widely implemented, if at all. Now remember, planning is important whenever they're taking their medication, so our primary therapy is levodopa for dopamine replacement, and they must take it with food. MAOI inhibitors, selegiline, phenolzine, it helps slow the dopamine breakdown, while COMT inhibitors like entacapone, tolcapone helps prolong the levodopa effects. We can also use anticholinergics such as benztropine, used for tremor control. Some of the common side effects include dry mouth, blurred vision, and urinary retention. Some of the advanced stuff that we can do, advanced interventions, is deep brain stimulation. Just a note for deep brain stimulation, this is adjustable and reversible. This is preferred when meds are no longer effective. That is why deep brain stimulation is preferred over lesioning procedures because it's reversible and adjustable, while lesioning permanently destroys. Now, here are the nursing diagnoses. So risk for injury because of their shuffling gait, rigidity, postural instability. They'll have anxiety due to the masked facial expression and slowed speech. They'll also have impaired social interaction due to the decrease in facial expression and communication, impaired physical mobility because of bradykinesia and rigidity, and they'll also have impaired swallowing, which is due to the weak tongue and throat control. This will increase their risk for aspiration. They'll also have impaired verbal communication, which is the low volume, monotone, delayed speech. Some of the interventions we can do is activity scheduling. So plan tasks during peak medication effectiveness, prevent falls by having them do a wide stance, have them use assistive devices, and remove any hazards. For the aspiration precautions, they can eat upright, take small bites, and we need to do a swallow screen to appropriately assess what they can and can't do. For mobility support, we want to use warm baths, gentle stretching, allow extra time for them to move. And for nutritional support, we want high fiber, adequate fluids, we want to monitor their weight. And for communication strategies, we want to use short sentences, allow response time, and speech therapy is going to be important for them as well. The focus of rehab is to promote home-based and transitional care. So for the evaluation of this, knowledge of their medications is going to be important. So patient has to be able to state the correct med dosing and timing, or someone needs to help them with that. They need to also demonstrate their ability to maintain daily schedule and routines. They have to make sure that they can utilize assistive devices to help maintain independence and be able to do those ADLs. We got to make sure they're able to express concerns related to their condition, and they have to be able to identify and use available support system, because again, these groups of patients are going to be at high risk. All right, guys, that should be it. Stay consistent, stay focused, and trust yourself. If you have any questions or concerns, let me know, and I'll see you next time.